AKI, just really briefly, kind of like a general overview of it and what we see here. So there are three main types, or when we're talking about AKI or acute kidney injury, we break it down into three different pathologies. There's the pre-renal pathology, there's the intra-renal, and then a post-renal. And they all kind of have their own different hallmarks of it. Pre-renal is caused by a decrease in flow to the kidneys. So anything that causes hypoperfusion, septic shock, other types of shock, hypovolemia, hemorrhagic shock, or when patients are bleeding, they're losing volume and the flow to the kidneys, the perfusion to the kidneys is going to be decreased. Intrarenal is a direct injury to the nephrons themselves. So the most common types that we see, there's like most of the AKI, it kind of falls under this intrarenal, but the ones that we see often are ATN, or acute tubular necrosis, which is caused by ischemia. So hypotension, hypoxia can cause ATN. AIN, which we see actually a lot, but it gets undiagnosed a lot. It's caused by inflammation inside the nephrons. Mostly we associate this with medications, but it can be caused by any kind of like allergic response. But the medications that cause an AIN are NSAIDs, PPIs, so like protonics are actually really bad for the kidneys. Bactrim is a common antibiotic that gets used outpatient that can actually cause renal injury. And then a lot of the beta-lactams, so any like the vancos, the carbapenems, things like that, anything under that beta-lactam category. Other types of intrarenal that we kind of see are things like glomerulonephritis, which is like another, almost like an autoimmune disorder inside the kidneys, vasculitis, nephritic/nephrotic syndrome, or other kinds of direct injuries. Rhabdomyolysis would fall under this pathology, hyperglycemia, hypertension injury over time, because those are things that are causing injury directly to the nephrons and the tubules and everything themselves. Post-renal is typically caused by some sort of obstruction with a urinary backflow to the kidneys themselves, causing damage from that backflow and that back pressure. We see it most often with kidney stones, and it causes an obstruction with backflow and that hydronephrosis, or sometimes people have like tumors and things like that. Anything that causes an obstruction. Kind of like a side fact, my sister had a post-renal kidney obstruction from being pregnant. Her baby's head was actually obstructing the ureter. So it was like a kidney stone causing this renal injury, but it was just because of the child's head inside of her. So anything that causes obstruction. So those are the three main like classifications of AKI. Now the big thing for it is A, recognizing an AKI, and B, knowing what caused it, because that leads us to how to treat it. An AKI by definition is, I didn't write this down here, but is a creatinine that is 0.3 greater than the patient's baseline, and urea for 24 hours, or if the creatinine doubles. So if somebody comes in with a baseline of 2, if it goes up to 4, that would be an AKI for that patient. So that's kind of like your definition of an AKI. And then one of the things that we use first, and that's like the quickest to help us diagnose AKIs, besides the overall story and the clinical picture, is actually looking at the UA. That can reveal a lot about what's going on with the kidneys that I think is kind of highly underutilized, especially by nursing staff. So in a pre-renal injury, you're going to have on your UA signs of dehydration or hypoperfusion. Again, what causes it? So if somebody's specific gravity is really high, their urine's concentrated, they're going to be hypovolemic. So increased specific gravity, there's going to be maybe signs and symptoms of infection, elevated white blood cell counts. Urinary tract infections tend to leave people very, very dehydrated with this kind of like pre-renal injury. And then on the BMP side of it, this is still the UA, if their sodium in their urine is less than 20, it tends to be a pre-renal, because that's a normal number, is less than 20. and a BUN creatinine ratio of greater than 20 kind of leads us to say pre-renal injury. Intrarenal, we tend to have very elevated protein levels for all of these things. You'll tend to see red blood cells in the urine without necessarily, you could have red blood cells without having a UTI or something that causes red blood cells that's like very obvious. Like you could have somebody without a GI bleed or without a UTI, but they still have blood cells in their urine. It's not just a mistake, it's an intrarenal injury. It's the kidneys themselves are bleeding, for lack of a better word. They're shedding the blood cells. If you see granular casts, that automatically puts you at an ATN diagnosis. ATN is the only thing that causes granular casts, and they are a one-to-one. They go together. That's like your insta diagnosis kind of right there. In an intrarenal injury, because it's the nephrons themselves getting injured, they're going to be dumping a lot of sodium. So anytime you see a sodium in the urine, that like a urine sodium greater than 20, you know that there's something wrong with the nephrons because they're being damaged and they're leaking them out. The only exception to that is if some patient's on like a diuretic of some sort, because that's how a diuretic works, is it pushes out more sodium. So that's kind of like your little caveat with the urine sodium. Not super accurate if the patient's chronically on diuretics. And then you'll also see a more narrow BUN to creatinine ratio. It'll be like less than 20. And I have examples, so you'll be able to like see that ratioing. A post-renal, it's gonna pretty much look normal, except for it's gonna look like somebody who's got a kidney stone. So they might have some blood in their urine. It might be completely normal. They might have some like uric crystals or other kinds of things. It might be cloudy, there might be sediment. It's just gonna look like somebody with a kidney stone, but otherwise, number-wise, is gonna be fairly normal. And then the kind of big thing whenever we have an AKI that we kind of ask ourselves is, does this patient need dialysis? What qualifies them to getting dialysis? What makes us finally pull the trigger on somebody with like an emergent dialysis? Assuming they aren't somebody who like is like a chronic dialysis patient. So we kind of use this acronym, the AEIOU are the vowels of the dialysis. A stands for acidosis, so if somebody's significantly acidotic, we'll see that on their BMP, we can see that on their pH on a VBG or ABG. We can use dialysis to help with that because when the kidneys aren't working, you have a buildup of acid in your system, and we'll use a bicarb buffer for that. So acidosis. E is electrolyte derangement, so E for electrolytes. Somebody's got a severely elevated and persistently elevated potassium. Phosphorus is actually an electrolyte that starts getting really built up in patients with renal failure. That's why you'll see chronic renal patients on a phosphate binder, which is typically some form of calcium to help bind to that potassium and drop the level down. So elevating phosphorus, elevating potassiums. I is intoxication. So if somebody does like a bunch of drugs or whatever and we need to dialyze them out for some sort of overdose, we can do dialysis for that. O is overload, for volume overload. We see that all the time. Patients come in and they need to get dialyzed for fluid overload. U is uremia, which is like an elevated BUN. The U in BUN stands for uremia, which causes an altered mental status, and in severe cases it can actually cause seizures in patients. So if they've got like a significantly elevated urea, then we can actually dialyze it out and that will drop it down. So when it comes to treatments, obviously the treatment for an AKI is fix the problem that caused the AKI, whether it's hypovolemia, give them fluid. If it's hypoxia, make sure they have enough oxygen. If it's shock, fix the cause of the shock, because otherwise the problem is just going to continue to worsen. Kidneys are pretty sensitive. They can recover, but they have a very narrow window in which they can recover, basically. So fluids, yes or no. Obviously pre-renal patients need fluids, whether it's blood, whether it's fluid, or something to help improve the perfusion. Intrarenal is where it can kind of get a little bit like tricky with whether they do or whether they don't. It kind of also just is the overall status of the patient. So you have to use their, like your physical assessment. Do they look volume overloaded? Do they look volume dry? The only kind of case where fluids don't help is in ATN, because the tubules are ischemic. They're completely necrosed, so they're dead. And as the one nephrologist I used to work with says, you can't water a dead plant and you can't water dead kidneys. So that has to just wait. ATN is the one where you just have to wait for those tubules to heal themselves for them to come back. It doesn't matter how much fluid you push at them, they're dead. So they have to just come back naturally with time and healing. Same thing with like Lasix, again, is going to be based on patient assessment. Do they look volume overloaded? Is it an acute injury where Lasix might be helpful for somebody? Is it somebody who's got like end-stage renal where Lasix is not going to do anything with them? The thing with Lasix is it's kind of like a level that work, and the level changes for different people for what the level of effective Lasix is going to be. So somebody who's used to Lasix, that level is going to go up and you're going to need more Lasix. Where somebody who's never been on Lasix, it'll be a lot lower of that border to cross for it to become effective. And like, yes, the Lasix itself, when we think of Lasix as nurses, a lot of times we go, oh, you don't want to give Lasix to somebody with a kidney injury because that can make their kidney injury worse, right? It doesn't necessarily itself make the kidneys worse. What it can do is make them really hypovolemic and further worsen an AKI. Just kind of depends on their overall volume status, right? Just like Lasix itself won't drop your blood pressure, just the medicine itself, it drops your blood pressure by you peeing out 2 liters and then your blood pressure drops. So if it's not effective, it's not going to like drop your blood pressure. If you only put out 300, you're not going to drop a blood pressure for that. So that's how Lasix drops your blood pressure. In and itself does not drop your blood pressure. And then the last thing we kind of like see is something called post-ATN diuresis. So when I was talking about these tubules in ATN, they get necrosed, they get ischemic, they're dead, they're no longer functioning. With time, as the tubules heal, suddenly your kidney function goes from maybe 20% to 50% as they heal, and you'll get this kind of post-ATN diuresis where these patients will just dump and dump and dump because now suddenly they have 2 or 3 times working kidneys compared to before, and the body takes a little bit to be able to self-regulate with that function again. So it'll happen a couple of days after whatever your initial kidney insult was. So if a patient comes in super hypoxic, maybe 3 or 4 days later, that's when we'd typically expect to see that ATN, that post-ATN diuresis. That's about the time frame for kidneys to kind of kick back on, as long as there's no continuing insult to them. So as long as there's not continuing sepsis or continuing hypovolemia or whatever, if you fix the problem, it gives them a couple of days and they'll be able to get it. The reason we're talking about AKI is we actually have somebody here today with a beautiful picture of ATN. So I actually screenshotted there. You can probably stop it at this point unless you want to look at the videos.